Let's begin before it betrays
Okay.
any of us. Network betrays any of us. All right. I'm starting the timer, and here is the question. Yes, please. Right. So if you have read and understood, kindly tell me what is your differential diagnosis?
Ulcerative colitis.
Your differential diagnosis?
It is ulcerative colitis, patient already known as ulcerative colitis.
No, but if once you are telling me differential diagnosis, then you should tell me 3, 4. One you said ulcerative colitis. Number 2 could be colonic cancer or something. Number 3, 4, considering the age. So tell me 4 conditions, please.
Okay. Can be Crohn's disease.
Yes, okay.
Uh,
But
for
it cannot be because patient is already known ulcerative colitis. This small lesion which has been diagnosed now could be cancer, could be what else? This,
it could be inflammatory bowel, irritable bowel
okay,
syndrome.
all right, okay. You will tell me next time for. All right, can you tell me what is ulcerative colitis? Can you define the term?
Ulcerative colitis is chronic inflammatory disease
Yes,
characterized by cholestatic ulcer.
yes,
Always involves the rectum and can
very good.
extend proximally to
Yes.
both the whole colon or part of colon.
Can you tell me what are the genes which are involved in ulcerative colitis?
Okay, it can be tumor suppressing genes such as ABCD gene
Yes,
and P53,
yes.
and also oncogenes such as KRAS.
Can you tell me in detail how these genes, what role these genes, each and every one of them play?
Okay, tumor suppressing genes such as ABC and P53 this act as gatekeepers, this inhibit the cell proliferation and also induce
Yes,
apoptosis, induce damaged cell with cause death of cell with damaged DNA. For the KRAS, it is
yes,
part of epidermal growth factor signaling pathway. This is
yes,
involved in proliferation of the cells and
yes,
tumor-induced new angiogenesis
yes. And
and
it
also
produces G
apoptosis.
protein. Yes.
Yes.
Okay. It causes apoptosis and tumor-induced neoangioplasty. Okay, very good. Uh, can you tell me what investigations? Okay, they have done colonoscopy. Why didn't they do sigmoidoscopy?
Because the risk of CA and also the whole colon is susceptible to be involved.
Okay, risk of bleeding maybe, and if there is CA. All right. Okay, can you tell me how frequent surveillance colonoscopy should be done?
You should do it every 6 months.
Okay, starting from what age? Until what age?
I think until the age of 25,
Okay, and starting from
maybe 6
10 to
months.
12. Okay, can you tell me what is the pathophysiology of ulcerative colitis?
The pathogenesis is idiopatic unknown, but it can be due to some factors such as can be genetic or due to family history,
Yes,
and also can be due to geographic variation.
yes,
due to host immune reaction between the host immunity and the intestinal microbiome, and also
Yes.
maybe due to some epithelial defect.
Yes. When a colonoscopy is done, how would you differentiate it from Crohn's disease? This is of another patient, colonoscopy. What do you see?
There is ulceration
Okay.
in the colon, and
Yes,
this is
more.
the thing, deep ulcer.
Okay. So once they ask you, you should at least know 3 to 4 points to tell about the image. What would you see in colonoscopy? How would you know that this is ulcerative colitis, not Crohn's disease? So tell me 4 differences, please. Why
The
it is
difference
not?
can,
Yes.
we can differentiate microscopically or macroscopic. On
Yes.
macroscopic, for ulcerative colitis, can be extensive broad ulcer, and also the studi polyp.
Okay.
It can only involve the mucosa, but
Okay.
not involving the res propria. If it is Crohn's disease, there will be transmural thickening and also the skip lesion.
Okay. Skip lesion in case of Crohn's.
Crohn's disease
Yes.
and
And there'll
cobblestone
be
appearance,
stenosis.
and
Yes, of
yes,
fistula formations if it was Crohn's. See, so you have to, all right. Okay, you tell me what should be the management of ulcerative colitis?
okay. After history and examination and do
Yes,
the
please.
investigation,
Yes.
we discuss in MPDT, and
Yes.
it depends on the stage. If the lesion is confined to the rectum, we
Yes.
can do only oral 5-amino acylic acid,
Yes, this patient has
or
it
we
in
can,
sigmoid colon, right? So it is less
okay.
than 1. So according to your grading and staging, how would you grade and stage this patient's condition? Yes, less than 1 centimeter in sigmoid colon. So how much, what level is this?
We use the Duke's criteria, but
Yes, good.
there's no mention of the lymph node, or
No mention of lymph
nothing
node.
is mentioned.
Yes, just the
My,
colonoscopy has been done. Okay, so
yeah,
nothing more. All right, can you tell me what should be the treatment? You were telling me about the treatment of the ulcerative colitis.
if it is stage 1, and we can do only oral medication, can do
Yes,
5-amino acylic acid. If it is extensive, can do broncholectomy,
yes,
anal pouch.
okay. So, all right. What else can you do? How would you, yes,
We
what,
can give
yes,
the corticosteroid or biological agents such as infliximab
okay.
or sifalimumab.
What other medications would you advise to the patient?
Medication.
Yes, any medications because patient is taking already immunosuppression. Would you add any other medication or would you ask the patient to stop anything for surgery?
Maybe start corticosteroid.
Okay, can you name few complications of ulcerative colitis?
Okay, can lead to deep ulceration and perspiration, and then lead to toxic megacolon,
Okay,
and there's maybe some perspiration and some extraintestinal manifestation, maybe primary sclerosing cholangitis.
yes. It can even lead to bleeding, osteoporosis, dehydration, inflammation, megacolon, liver disease, colon cancer, and one word, fulminant colitis. Can you tell me
Okay.
what does that mean? Fulminant
Since
colitis?
this is involves the whole colon is involved.
Okay. And patient has severe attack.
Okay.
Yes. intestine stops moving, and yes, it belly swells. All right, right, all right, all right, all right. What about the prognosis of the ulcerative colitis? Bell is gone, but I was asking you very casually, so please allow me one or two more questions.
The prognosis,
Yes, please.
I can't recall.
10%.
For the 5-year survival,
Yes, if you can tell me 5-year survival. They say
10%.
10% they get very worse. Their condition gets very worse, and with serious complications. Others remain more or less okay. Right. How should a patient with ulcerative colitis manage its flares? What measures should they do? Does
Hello?
probiotics, yes, I was waiting for your answer. Does probiotics play any role in ulcerative colitis?
Antibiotic? I don't think so.
Probiotics. Probiotics, not antibiotics.
Uh, can use only biological agent.
Yes.
Don't know about
Do they play any role? Do they help? These are just placebo supplements, nutritional supplements. Can they help?
I, thought- I think it can help, but I'm not aware of this. Don't know.
Okay. Okay. You'll read now.
Okay.
Yes, please. And then when we'll revise again, then you'll tell me. Thank you.
Thank you.
Thank you so much. Yes. Somebody was raising hand. They wanted to say something. Yes, please add now. So how would you know on histology? I couldn't find any histology of ulcerative colitis. So I got one
In histology, we
colonoscopy.
will find microscopic and macroscopic.
Yes. Tell me
For the
please both.
microscopic, it is the same for Crohn's disease. You will do infiltration of the neutrophil, and also you'll be cryptemic, you lead to crypt abscess,
Okay.
and also the formation of the pseudo polyp
Yes.
for the ulcerative colitis. Microscopical on gross examination or macroscopically, we will find the pseudo polyp and extensive brown ulcer, and also it is not transmural as in Crohn's disease, but it's only
Yes.
confined to the mucosa, not involving the muscularis propria.
Yes.
For ulcerative colitis. For the Crohn's disease, if you are asking me,
Yes. I was
for
asking
the
you the
Crohn's,
difference. How would you know if it's not Crohn's, it's ulcerative colitis?
okay, for the Crohn's disease, also microscopic, I will see crypt abscess and cryptemic, but there will be skip lesion and non-cascading granuloma.
Yes.
The non-cascading granuloma is the hallmark of Crohn's disease,
Yes.
and also there will be neutrophil infiltration as well. And macroscopically, there will be the skip lesion and couple stone appearance with the stricture formation. Here the involvement is transmural. Both all the rare mucosa and submucosa and pseudophobia and the cirrhosa. There will be some vesicular formation and
Yes.
obstruction
In
of the
Crohn's.
stricture.
Yes.
Yes.
Yes. Very good.